Dr. Skoutas, thank you very much for the kind introduction. I would like to thank also Professor Koutsis for the very kind invitation. Indeed, this is an interesting question, and I hope to find some answers. These are my disclosures. So let's start with defining remission. What is remission? It's practically not needing taking any glucose-lowering pharmacotherapy. And why is remission important? Why we discuss about remission more and more these days in congresses and in papers, etc. Well, first of all, we have to admit that type 2 diabetes is a nasty disease because, as you can see on this slide, type 2 diabetes has poorer survival rates compared to many malignancies like breast cancer or some lymphomas. And there is no doubt that people with type 2 diabetes tend to live less, to die younger, compared to normoglycemic controls. So maybe the most important thing about remission is that if we ask our patients, not ourselves, not researchers, not clinicians, but if we ask the patients who have type 2 diabetes, what is the most important priority about the research in the future in the field of type 2 diabetes? Patients will answer that they want to find a cure, a definite cure about type 2 diabetes, because I think it is obvious that no one is happy when taking medications about diabetes, hypertension, hyperlipidemia, etc. So remission is important because obviously if we achieve remission, we can avoid or delay at least diabetic complications, because it empowers people with diabetes to manage their disease in a better way, because of course they don't need to take medication, because remission is associated with the loss of diabetic stigma. And to be honest, we have to admit that there is in the society, there is out there a stigma about diabetes. Let's say it's not very easy for the majority of our patients to make insulin in public, in a restaurant, let's say. And finally, I think it sounds reasonable that if someone achieves remission, then will cost less money to the healthcare systems, to insurance companies, etc. So it is also cost effective. So the big question is, how can remission be achieved? And there's no doubt that the most important driver of type 2 diabetes is adiposity, is obesity. And we have some good data from landmark trials like the TPP program, that if someone loses a lot of weight, then he or she can lower the probability, the future probability of developing type 2 diabetes. Let's say in the DPP program, we showed that losing weight was more effective even than drugs, even than metformin, in reducing the future probability of type 2 diabetes. So maybe the most important trial in the field of remission is the DIRECT trial. We're all familiar with this study. It had two arms: the control group, in which participants took the standard of care, and the intervention arm, which included a structured weight program. Of course, it is important to say that the DIRECT trial took place in primary care settings and not in specialized diabetes centers. It is also important to keep in mind that participants in the DIRECT trial had a very short duration of diabetes, and this is important about the time frame in which we should try, or we should ask our patients to try to achieve remission. So what the DIRECT trial showed, it showed that if someone loses a lot of weight, particularly more than 15 kilograms, then it has he has a great probability, almost 86%, to achieve remission of diabetes and to stop taking glucose-lowering drugs. But also this trial highlighted that the benefits of remission extend beyond diabetes control. And for example, the DIRECT study showed that remission is associated with a better management of blood pressure, and with a reduction in the number of antihypertensives that are needed to maintain optimal blood pressure. The DIRECT trial didn't evaluate cardiovascular outcomes, but participants who achieved remission also managed to improve their cardiovascular risk scores, and I guess that this is also important. But maybe the most important benefit beyond diabetes control is that remission seems to be associated with an improvement in quality of life, and this is very important for our patients. Also, there is a great discussion in the literature about MASLD, the new definition or the new name of NAFLD, and people who achieved remission in the DARK trial also had a significant reduction in the liver fat content. And also, maybe the most important mechanism that explains remission is the return of the pancreas to a normal morphology and the improvement, the great improvement in the function of beta cells of the pancreas. So another good question is, who is the ideal candidate to achieve remission, or at least to try to achieve remission? And this study showed something very interesting, that people who are young and who have a low burden of complications and a low number of comorbidities have the greater probability to achieve diabetes remission. So the message is that the best time frame to try for remission is very early after the diagnosis, the first year after the diagnosis of diabetes. So this is another sub-analysis of the DIRECT trial, which showed that people who achieve remission cost less to healthcare systems, and this, I guess, seems reasonable, because if I don't take any medication for my diabetes, probably I will cost less for the healthcare system. So the message is that if we achieve remission, we live longer, we feel better, and we probably cost less to our insurance company. So what are the strategies for achieving remission? And we'll start with diet. And the traditional knowledge says that the most important driver for remission is the magnitude of weight loss and not the type of diet. It's not so important if I manage to lose weight by eating, let's say, a Mediterranean type of diet or an Indian diet, etc. So the main driver seems to be losing a lot of weight. During the last years, we have published some papers on the orthodox fasting, which is a subset of the typical Mediterranean diet. In these papers, we have compared the Mediterranean diet, the orthodox fasting, with time-restricted eating. And this is one of the latest papers in which we showed something that is very important, and I will say that our findings challenge the traditional approach about how people can achieve remission. So we found that despite losing the same amount of weight, both people who practiced the Mediterranean diet and people who practiced TRE, time-restricted eating, despite losing the same amount of weight, only the group of Mediterranean diet showed a significant effect on nesfatin levels and on beta cell function. So our findings suggest that it is not only the magnitude of weight loss, but also it is important the way the dietary pattern through diet loss is achieved. So physical activity, of course, is important. We know that there is a larger effect of diet on total body weight loss, but exercise seems to be very, very important for reducing visceral adipose tissue, and we all know how important is the reduction in visceral adipose tissue in improving metabolic outcomes. And this meta-analysis showed something which is very interesting, that if we combine the two approaches, if we combine both diet and exercise, then the probability of achieving remission becomes greater and greater. So I presented to you so far the benefits of diabetes remissions, but as it happens with all things in this life, there are not only benefits, there are also some challenges in pursuing diabetes remission. And I don't know if you remember from the school times, but Apostle Paul, who was the slaughter of the Christians, in his road to Damascus sees a vision, and within a few seconds, Paul is transformed to the most loyal student of Jesus Christ. I refer to this paradigm because, in theory, we would like from our patients in the clinic daily to live, to experience their Damascus experience. to explain to our patients how important it is to live a healthy life, to lose weight, to exercise, and our patients to transform within a few seconds to people who live in a healthier way. But this, as you probably know, is rarely observed in daily clinical practice. It is very hard for people to change their eating habits, their everyday habits. So we all know, I repeat, both from daily practice, but this is obvious from clinical trials as well, that it is very hard for people to maintain weight loss in the long run. Maybe it is easy to lose weight, but it is very, very challenging to retain this weight loss in the long term. And you can see that this is applicable for any type of diet. And this is confirmed by the findings of the direct trial, which showed that at 2 years of the study, the percentage of participants who retain remission is much lower compared to the percentage at 1 year. So as time passes, people who achieve to retain diabetes remission become fewer. And finally, I will say that this is a challenging approach, but why not combine both lifestyle change and medication to achieve diabetes remission? This is one of our oldest papers published in the Drugs Journal, in which we suggest that people who have a short diabetes duration, young people with type 2 diabetes, should be aggressively managed with both, of course, lifestyle changes, but also with a combination of GLP-1 receptor agonists and SGLT2 inhibitors, because we have strong enough data that this approach can result in weight reduction, in diabetes remission, in optimal diabetes control, but most importantly, in a significant reduction in the cardiorenal risk and maybe in prolonged survival. And we also know that combining these two novel drug categories is associated with improvement in fat liver or in other diabetes comorbidities. And also this is one of our oldest papers with some colleagues from the King's College, where Stella is working now. And we suggest that SGLT2 inhibitors may be spin the thread of life, may prolong life duration through a plethora of mechanisms that are very complex but also very interesting. And this approach is confirmed, is supported by a recently published trial from Italy. In this trial, the authors showed that pharmacological remission of diabetes is manageable, is doable if we combine an SGLT2 inhibitor like dapagliflozin with oral semaglutide. And there's a great discussion in the literature these days that the definition of remission should change, because in its current form, the definition of remission excludes pharmacotherapy. And this is a problem because, as you know, the diabetes guidelines, the guidelines for the management of type 2 diabetes, advocate the use of the neurodiabetic agents even in people who have adequately controlled diabetes, because we know that these drugs can reduce cardiorenal risk in a way that is it is not directly dependent to the management of glucose levels. So my take-home message is remission is an emerging target in the management of type 2 diabetes. I believe that we will discuss more and more the next years about remission. It is obvious that the major determinant of remission is weight loss, but we should keep in mind that it's almost impossible to retain weight loss in the long run, and this is a big challenge. We certainly need more prospective data on the association between remission and complication risk, but my personal take is that the best way to travel is combining the new diabetic and weight loss medication with lifestyle changes to achieve remission. If someone is interested in reading more, we have summarized all this data in a review article. It is open access. It can be downloaded free of charge. And I would like to thank you with a quote by Roy Taylor, who, as you know, was the principal investigator of the direct trial, who said that remission is like managing to climb on Mount Everest. There are a lot of people each year who try to climb Everest, but only a few of them actually manage it. Thank you very much for your attention.